to March's installment of DDD's First Tuesdays training series. Can you believe it's March already? Today, we have two guest presenters from the Developmental Disabilities Division. Miss Linda Austin received her Bachelor's of Science and Dental Hygiene degrees from the University of Hawaii at Manoa. She subsequently worked in private practice as a dental hygienist for over 30 years and taught at the University of Hawaii Dental Hygiene Program for 15 years. She currently works for the Department of Health Developmental Disabilities Division dental branch, focusing her research on access to care issues that our kupuna and persons with disability frequently face. She works in the community and hopes to stimulate oral systemic awareness and increase dental hygienist recognition as a vital health team members in our community and institutions. Also presenting with Miss Linda Austin is Stephanie Guieb. Stephanie, who has been in nursing practice for many years in a variety of settings, the last 18 of which are with the Developmental Disabled Waiver Program, both as a nurse case manager and currently as the clinical team nurse. Stephanie holds a master's degree in nursing with a certification in developmental disability nursing. It is with my honor that I turn today's presentation over to Linda and Stephanie. Stephanie, take it away.
Hi, good morning. Thank you so much for joining us this morning, taking time out of your busy schedule. It's a pleasure to be able to present this information to you, aspiration prevention and the oral systemic connection to well-being. I would like to premise our discussion regarding when Linda and I refer to participants, clients, or individuals, we are referring to individuals who have been diagnosed with either an intellectual or developmental disability and are currently receiving services within our DD waiver program. Thank you. Let's get started. So if we're looking at our learning objectives, what we would like to focus on is that you gain an understanding of normal swallowing, dysphagia, and aspiration, being able to recognize risk factors for aspiration, contributing factors, and also possible signs, while understanding the importance of early detection of dysphagia, and then be able to identify steps that will help you to safeguard our individuals. Next. So what is the significance of training? I had sat, and I have sat since 2010, on the mortality committee for the division. And what we were finding is that aspiration pneumonia is a very prevalent and a preventable cause of death in our individuals. I also, while earning my master's degree, had used all of my focus during that program, because you do a lot of research leading up to a capstone, was all on our population, the IDD population, and then more pointedly at aspiration pneumonia. And this shows that there's a significant impact that dysphagia has on this population. Next. So if you look at the current US population, which is growing, currently it's about 330 million people living in the US. Of that population, 2 to 3%, or about 6 to 10 million, are individuals diagnosed with an intellectual developmental disability. 20% also have dysphagia. Now, keep in mind that dysphagia may not always be diagnosed. So let's look. So what is our average age of death? Now, this chart, it does have some older information, but in 2019, the general population in the US, life expectancy was at 78.8. It is currently has dropped to 77 years. In Hawaii, we're able to experience a longer life, thankfully, at about 81 years. By contrast, though, for our DD population in the country, on average, it's about 66 years of life. And more markedly in Hawaii, I had looked at and taken an average from 2012 to 2017, it is 52 years of life. So that's about 25 or 30 years of life lost. If we consider we're able to most times on average live for 81 years. So let's see how we can positively affect that. Next, if we're looking at leading causes of death in the general population in 2019, heart disease, cancer, stroke, accidents, Alzheimer's disease, or dementia. In our DD population, it's also heart disease, but look at the next three: respiratory failure, aspiration pneumonia, septicemia, and cancer, and then renal failure. Now, when you look at respiratory failure and septicemia, it does not indicate what the initial cause was. Did the respiratory failure start with an aspiration or community-acquired pneumonia, or perhaps chronic lung conditions? It doesn't say. And as well as septicemia, could that sepsis had started as an aspiration pneumonia? Regardless, respiratory conditions and pneumonias are leading cause of death. It's both preventable and prevalent. So what is next? What is dysphagia? Now, we take it for granted when we swallow, we just swallow. We don't have to think about it. We just drink a sip of water and swallow. But swallowing is a very complex neuromuscular function. It involves normal functioning nerves, muscles, and organs. According to the American Speech and Hearing Association, there's two phases to swallowing: the oropharyngeal phase, where you're chewing, you're initiating the swallow, moving the bolus from your pharynx to your esophagus, and the esophageal phase, where you're moving the bolus from your esophagus into your stomach. By contrast, with dysphagia, you're having difficulties with swallowing that could be either obstructive or a motor disorder. Next. Now, I like diagrams. I'm a very visual person. So being able to see it, it helps me to learn and helps it to be understanding. Okay, if we look at on the left, diagram A, you will see the blue arrows, and I wish I had a cursor, but I do not. The blue arrows are when you breathe in. That's your oxygen. You're breathing in, it's going to the back of your throat, and normally it is going down into your trachea and into your lungs. So you're being able to be aerated. And then you'll see this large yellow figure in the back of your throat. Now that is a bolus of food. When we chew our food, and of course we can't see it, but it forms a bolus. And then in the middle diagram, that bolus of food is actually moving down into the back of your throat, way behind your tongue. Below that bolus, you will see a blue kind of angular figure there. That is your epiglottis. In normal swallowing, the epiglottis closes over your trachea. And if you look at diagram C, when it's closed, that bolus will appropriately go down into your esophagus and into your stomach. So that is normal swallowing. Next. Now I have a video attached. This video we will not show this morning, but it will be available on the training website. There'll be a link there. Please watch it. It's an excellent video of normal swallowing, and it explains it more thoroughly. Next. So let's look at risk factors for dysphagia and aspiration. Now there's a long list. This is not all inclusive, but it's a list of conditions that can contribute to an increase of dysphagia and aspiration. Now, some of our individuals do have cerebral palsy, spastic quadriplegia, but this leads to muscle spasm. So if you think of someone having a muscle spasm, aren't they more likely to choke and not be able to swallow appropriately? How about when one of our individuals is having a seizure, and maybe perhaps they just ate, they just swallowed water, very high risk for aspirating. or perhaps they just have saliva in their mouth that they could also aspirate. Scoliosis, you actually have a physical condition with malformation of your spine, and everything is not in alignment to promote appropriate swallowing. If someone is diagnosed with GERD, and that's a common condition that we see in our population, or gastric reflux, it's actually, and even say you have a large meal and you have that regurgitating feeling, there's gastric acid included in that. So it's very dangerous to have that condition and land up aspirating that into your lungs. Dementia, someone with dementia, maybe not chewing appropriately, eating a lot of food. And we do have some individuals that eat and kind of stuff their mouths, and high risk for aspiration. Also included numerous genetic conditions, lung disease, Parkinson's. With Parkinson's, you do lose your ability to coordinate your movements, and that includes swallowing. Now, how many of our individuals are on medications, and numerous medications? Now, this is a short list. The anticonvulsants, benzodiazepines, analgesics, and many psychotropics. Those come with side effects. And if you have multiple medications that you're taking, it becomes synergistic, or they add on to each other, as far as perhaps promoting altered mental status and an ability, and that will affect your ability to swallow appropriately. Now, if someone's not able to communicate that perhaps they're full, perhaps it's difficult to swallow, they're having pain and difficulty in swallowing, they would be at higher risk for aspiration. Now, later on, Linda is going to expound on poor oral care and health, and how this will affect aspiration. If you have a mouth that is not well cared for, it's full of bacteria, and she has many diagrams on that. She will expound on that. And improper positioning during and after feeding. If you're lying down and eating, you're at risk for aspiration, even if you can swallow well. That everything is not lined up, and I can't say enough about proper positioning during and after meals. Next. So what are the possible signs of dysphagia? Now, if you look down this list, you going down the wrong pipe. That's a very simple statement, but I don't know if any of you have experienced that. I certainly have. Very uncomfortable, very painful, and scary, because you're not able to catch your breath. For some of our individuals that don't have a strong cough or gag reflex, that could even, be a worse outcome. For someone that's not able to manage their secretions and swallow appropriately, they may display drooling. It may be a new sign. Coughing while they're eating, or frequent cough. Maybe they cannot swallow medications that they previously could. Weight loss, they're not trying to lose weight and they're losing weight, or they're not interested in eating. Having a moist voice after eating, and really having maybe a history of respiratory infection. Now, if they're being treated by the physician would be aware of this, but these are all possible signs of dysphagia. Next. So what is aspiration? And here's another diagram on the left. That's appropriate swallowing and breathing in of air. You take in air with the blue signs, either if you're a mouth breather or through your nose. It goes down into your windpipe and down into your trachea and into your lungs. No problems with that. You ingest food, you chew it, you form a bolus, and you can see that bolus is going down in your esophagus into your stomach. On the right side, though, that's an aspiration. You can see that bolus of food is clearly in the trachea. This requires immediate attention. Next. Aspiration pneumonia is defined as the inflammatory condition of the bronchioles and lungs as a result of the aspiration. Now, is anyone aware, and I know you can't answer me directly now, but is anyone aware of why we see aspiration pneumonia more prevalently in your right lung? And it's called, our bronchiole, it's a larger caliber and it has a more vertical orientation of the main stem bronchus into the lung. So like if what you call simply a straight shot. Now, can you have aspiration pneumonia in both lungs? Oh, assuredly, you can aspirate in both, but it is more prevalent in the right lung. Next. Now, in researching, and I have stacks of research documents and spent hours researching for my capstone. And I was looking at what would benefit, how can we benefit and assist our individuals in preventing aspiration pneumonia? And what came up repeatedly, and these are just 4 examples, but what it pointed to is early identification of dysphagia and the use of a screening tool. So when you're doing research, you're looking at studies for reliability, where they're consistent and expected to perform well, and they're valid, meaning that the findings will truly represent what's being measured. So all of these indicated a need for early screening for dysphagia to prevent aspiration. Next. Now, this is a sample, and I will have, and Abby has formulated it with check boxes. Thank you, Abby. And this is available on our website. This is a sample of a screening tool by Franciscato. I found it to be one that is simple to use. It can be used across settings. It was used in a long-term care setting, but it can be used in the community, in the family home. Any of you can save it and print it. If any question is answered yes, please advise the guardian if you are not the guardian, and make an appointment with the PCP for follow-up. This is indicative that this person may be having dysphagia. Next. Now we talk about, and then it's a common term, a circle of support. But it takes a village to support our individuals. It starts, of course, with the family and guardian, and then our caregivers that are overseen by provider agencies, with case management services and case managers looking at appropriate services and recommendations. Our clinical team, which I'm a part of, outcome and compliance branch that also oversees all of the appropriate appropriateness of services, our medical providers out in the community, and then also our community resource branch that oversees provider agencies, and our dentists and hygienists in our dental services branch. So now I would like to transition this over to Linda. She has a very interesting oral systemic connection. Go ahead, Linda. Next.
Well, thank you for this opportunity to present today. On the dental perspective of aspiration prevention and the oral systemic connection to well-being. Before I begin, I just wanted to say again that, like Stephanie, I will be using different terms to describe the persons that we are caring for. So this session is a brief overview of the importance of teeth and how oral health affects our overall health. I would like to bring awareness to why the best dental hygiene practices are especially important for our IDD population. I'll show you the tools that we use for those who need our assistance. And I would like to mention that your circle of support is very important. And just know that you are supported by different professionals that care for your individuals. It's important to collaborate and to achieve the best outcome for the person that you're caring for. And that includes an oral health professional, a dentist or dental hygienist. And we are very fortunate that the dental branch is part of the Developmental Disabilities Division. And I will share with you the obstacles that block good oral health care for the person with IDD and what you, the care provider, can do when you see or smell tooth decay or dental infections. So our mouth is one of the most important parts of our body. We need our teeth to eat, to drink, and to live. If your grandparent is living in a nursing home or long-term care facility, it would be nice for them to be able to chew a healthy meal rather than drink a liquid diet. So let's keep our residents eating healthy by keeping their teeth healthy. Next. So let's explore Ensure as an example of a sugary food. Although there are strong reasons to serve Ensure to patients for nutritional or personal preference, Ensure can contribute to dental decay when it's sipped throughout the day, which happened to my auntie. So although 19 grams of sugar may not seem like much, we look at ingredients. And if sugar is listed as one of the first 4 ingredients, which this is, sugar is listed as number 3, we consider this a sugary food. So Ensure does have a lot of hidden sugars, and every sip is a sugar attack on your teeth. And that's contributing to the individual's excessive tooth decay that you may see or smell, which we often see in long-term care facilities. This is the result of sugar exposure and an unclean mouth due to lack of daily care. The good news is, though, sugar exposure can be reduced by including sugar-free foods. So let's make our children and our residents' diet cavity-free. Next. So teeth are important to communicate with others. With a healthy mouth, we talk, we smile, and we laugh. Sometimes it's very difficult to understand what a person is saying when they are missing their teeth. Ever experience bad bacteria breath when someone is talking to you or near you? Again, let's keep our children and residents' mouths clean and odor-free. When we are free of mouth pain, we feel our best, upbeat, and positive. A healthy mouth reflects our mental, our physical, and social well-being. But when a person is suffering from a toothache, they're usually very unhappy. So let's keep our residents pain-free so that they can enjoy a better quality of life. Next. When a person has untreated gum disease, that gum infection could lead to aspiration pneumonia. Research has shown that the bad bacteria in your mouth can travel through the bloodstream and infect other parts of the body and exacerbate existing inflammatory conditions such as heart disease and diabetes. That bad bacteria can also be aspirated from the mouth into the lungs, leading to aspiration pneumonia, as Stephanie described in her slides. Volumes of research has shown that pneumonia is the leading cause of death in nursing homes. And this is similar to Stephanie's research on the IDD population. Researchers have isolated bacteria in periodontitis, which is a chronic infection of the gums, and found that same bacteria in the lungs of patients with aspiration pneumonia. Bacteria in an unclean mouth, which is when you don't brush your teeth before going to bed, that bacteria can easily dislodge from your teeth and be aspirated while sleeping. As Stephanie explained in detail, This is a short list of risk factors that make the person with disabilities more vulnerable to aspiration. These conditions make it more critical to provide good daily mouth care for our individuals. A clean mouth free of bacteria will lower the risk of aspiration pneumonia. Next. Many people with developmental disabilities have genetic disorders, making them more vulnerable to dental disease. Many have genetically compromised immune systems. So daily mouth care must be made a priority and placed on the same level of importance as taking medications. And like medications, a healthy mouth can protect your whole body. So keeping a clean mouth is even more important for the person with disabilities. Next. A risk factor for dysphagia and aspiration pneumonia is dry mouth. Over 500 medications, and now they're saying 700 medications can cause dry mouth. The more medications a person takes and the stronger the prescription, the drier their mouth will be. And as Stephanie mentioned, the people with disabilities may take a multitude of powerful medications, which means that they will have an extremely dry mouth that increases their risk of hospital and nursing home pneumonia. Next, with poor oral health and a dry mouth, cavities are out of control when exposed to sugary foods, as with Ensure. Dry mouth could cause chewing and swallowing problems and pocketing of food that could be aspirated. So it's really a good practice to rinse after each meal. Dry mouth can lead to a burning pain and discomfort that lowers a person's quality of life. So what happens when your individual is nonverbal and is very uncomfortable with a dry mouth? A lot of times they are the most grumpiest person in your home. So we must all be aware of the medications that this person is taking and find out what their level of discomfort is. Dry mouth can also cause severe bad breath or halitosis. And if you ever smell horrible bad breath around you that makes you feel kind of weak, you must immediately think, next, that person has a dental problem, either a tooth decay or gum infection, and really needs to see a dentist. Next. So caregivers work directly with their individuals. And when there's a mouth problem, they are the first line of defense. It is very important to get that individual to the dentist. With the help of the circle of support, dental disease can be treated and prevented. Next. So dentistry only treats two chronic diseases, tooth decay and gum disease. However, going to the dentist is only a small part of overall dental care. Daily mouth care is essential and prevention is key. Next. So the goal for daily mouth care is to remove the bacterial plaque to keep a healthy mouth, to avoid mouth infections and lower the risk of aspiration. So what is plaque? Plaque is a soft, sticky film that contains bacteria that forms on your teeth. If not removed daily, the bacterial plaque may decay your teeth or harm your gum tissue, and both are considered to be infections in your mouth. Plaque is invisible but can be felt. So I want everyone to use your tongue to feel your teeth. If it's smooth and slippery, your teeth are clean. If it's sticky or bumpy, or you feel some resistance, you are feeling plaque, and that plaque can be removed. You must clean the plaque off before problems begin. It is important to teach the plaque test to everyone you know, especially children, because everyone will benefit when they can feel a clean mouth. Next, sugar is the fuel source for the bacteria. Bacteria only love sugar for food, and its byproduct is acid, which decays teeth. And anything that is decaying means that it smells very bad. Too often, people with disabilities eat a diet high in sugary foods and suffer with big cavities. If the tooth decay is left untreated, the bacteria enters the inner part of the tooth where the nerves and blood vessels are located, and this results in a bad toothache. And the toothache is painful because the bacteria is hitting the nerves, as you can see in the picture with the decayed tooth. If the diseased tooth is not treated, bacteria and its byproducts can enter into the bloodstream and may cause sepsis and possible death. Next. Gingivitis is a mild infection of the gum tissue. During the early stage of periodontal disease, you and your participant can prevent severe dental disease or gingivitis. Gingivitis is reversible and will heal with proper daily mouth care. The individual with gingivitis may see a little bit of bleeding on the toothbrush and may feel some pain and swelling. Their breath may smell stale, but not bad. Next. But when gingivitis is left untreated, the infection worsens. Periodontitis is a severe chronic infection of the gum tissue. It's irreversible. The damage is irreversible. And the bacteria and byproducts destroy the bone around the tooth and soft tissue, ultimately results in tooth loss. Chronic periodontitis is a leading cause of tooth loss in adults. The bacteria and its byproducts that are destructive in the mouth can enter the bloodstream and lead to other systemic conditions such as heart disease, diabetes. Now they're looking at Alzheimer's and pneumonia. Many people with IDD are more vulnerable to these disorders because they are immunocompromised. Next. So please don't wait till your participant's mouth looks like this. Next. We must get the word out that dental disease can be prevented. To prevent means to stop something from happening. Proper daily mouth care can prevent dental diseases, and a healthy mouth improves a person's overall health and quality of life. Next. Currently, the Department of Health and Hawaii Dental Service Foundation are partnering to provide in-service training in nursing homes for the elderly. Please watch this video that the nursing staff views prior to the training on caregiver oral hygiene basics. I taught for 15 years at the University of Hawaii Dental Hygiene Program, and I looked at hundreds of videos on brushing techniques, and this is the best I've seen so far. It's very good, very informative. Next. In this training, we teach the staff the importance of oral health and how to approach their resident's mouth with a gentle touch so that they can achieve effective toothbrushing techniques. We also teach them how to do a look-see for any signs of dental infections, such as next, brown spots or cavities on the individual's teeth. Caregivers should look in the individual's mouth at least once a month for the independent person, or they must be aware of brown spots when they're brushing their individual's teeth. Next. They should also look for swelling on the face, asymmetry, where there's swelling on one side of the face, not the other, and changes in appearance or behavior. If the nicest resident suddenly becomes grumpy, you need to suspect an oral problem. Next. The caregivers must look for swelling inside the patient's mouth, and if present, the individual must see a dentist immediately. It's considered an emergency. The swelling may lead to sepsis in the blood and considered neglect if you wait too long. Next. Have you ever seen this? This is a little sponge on a stick. It's called a toothette, and the toothettes should be used to deliver liquids to hydrate a person's mouth. However, toothlets are being marketed as a substitute for toothbrushing. And unfortunately, it is widely used in long-term care facilities. If you read the fine print on the package, it states, ensure the foam is intact after use. If not, remove any particles from the mouth. So these spongy particles can be aspirated. So the use of toothlets for plaque removal must be stopped, because this is what can happen if you use toothlets for a toothbrush. Next. My friend asked me, Linda, who's responsible for cleaning my dad's teeth at the care home? This is her father's mouth. She sent me this email. Here's a picture of my dad's mouth while he was in the skilled nursing facility. It also looked like this while in the hospital. CNAs used a green sponge without success, and use of a toothbrush was more effective. She also mentioned that the CNA told her that they were advised by their nurse supervisor to use a toothlet for daily mouth care and only clean the front teeth. And you can see from this picture that using a toothlet is very ineffective. So how do we avoid these problems, these serious problems, and keep a healthy mouth? Next. Just by toothbrushing. It's so simple. With or without disabilities, toothbrushing and complete daily mouth care are essential to keep a healthy mouth. Next. So this is a long list of contributing factors that make toothbrushing more difficult for a person with disabilities. You may recognize some of these conditions in your own individual that you're caring for. As a primary caregiver, you must practice patience, creative approaches. You must realize that sometimes it may take time to achieve good toothbrushing. You must use a gentle touch, but it must be firm. And most importantly, you need to know your participant and learn and practice desensitization techniques. So I did give a handout with suggestions on how to overcome some of these obstacles. Everyone should clean their teeth at least twice a day to keep a healthy mouth. Use a toothbrush with soft bristles so you don't damage your gum tissue. Change your toothbrush every 3 to 4 months. The toothbrush is the best and safest tool for mouth care. Toothpaste is not what cleans your teeth. It's not necessary when a person is having difficulty swallowing. For yourself, you just need a pea-sized amount of toothpaste, if any. Next. A 3-sided toothbrush and foam wedge can be used when a person cannot open wide. Many of our caregivers use the 3-sided toothbrush to help their residents brush their teeth. Modified toothbrush handles are great for someone who has arthritis or an injured hand. Next. When flossing is difficult, Christmas tree brushes, floss holders, and rubber tips are great tools to clean between the teeth, especially when working on someone else's mouth. The tool that you choose is not as important as disrupting the plaque off from between your teeth daily. So if I'm working on someone, I prefer the interproximal brushes or the Christmas tree brushes. So daily mouth care must be made a health priority. The goal is to prevent disease for you and the people that you care for, to stay healthy, to enjoy a great quality of life. So what is our safety net for preventing aspiration? Stephanie will explain how to better protect the people you care for from aspiration.
Next. Thank you, Linda. That was an excellent information that we can all apply to ourselves as well as the individuals that we're supporting in promoting excellent oral care. Now, looking at our safety net, next, And I had spoken earlier about it takes a village. It takes a village to work and really encompass our individuals to provide excellent care, but it involves different components: education, communication, and collaboration really all work hand in hand to safeguard our individuals. If we look at the education component, we're looking at training like this, where you're learning about dysphagia, aspiration, and oral care. How can you help support your individual, considering safe mealtime support as well. If that person has been diagnosed with dysphagia, you'll have a speech therapist on board, and they will provide specific recommendations and orders, and utilizing training in upright positioning during and after meals, feeding the individual slowly, and of course, notifying the PCP if there's any question, if there's anything, any sign of aspiration that is suspected, please prompt notification to the guardian and to the PCP so that they can intervene. Next. Now, communicating, everyone needs to communicate. I cannot emphasize this enough. Communication, like I just said, to the PCP, of course, to the guardian, service supervisor, or case manager should be aware that there's a problem going on. And our written communication to our service plan for our, what we call participants in our program is crucial. We need to be very thorough in making sure our diagnoses are up to date, the diet orders and the risk factors are there and indicated. You know, anyone that picks up that document should be able to be clear on how they're going to support that person. Our action plans and IPs will provide specific interventions. And in the circle of support, if you're in the circle and you notice perhaps the case manager hasn't indicated that there's a diagnosis, there's a risk factor, please speak up. You all have an equal voice, and we want to make sure that we support our individuals. Some of our individuals have nursing delegation plans and training that will help support and mitigate risk factors. Medical reports should be included and up to date, requested from the PCPs, having our caregivers provide that to case managers, and our family members also asking the PCP or primary provider to give you a copy of latest test results or medical reports. Our adverse event reporting advises when an event has occurred. This notifies the circle. Closer scrutiny and intervention is needed to safely support that individual. Next. So all of us as stakeholders working in collaboration, sometimes our case managers will call, sometimes they'll call me as a member of the clinical team, or they'll make a referral to our clinical team that also has our medical director and our licensed social worker on board. And so we can review documents. We'll ask for a lot of documents because we want to understand really what is going on with this individual, and then provide recommendations to the team to be able to see what our next steps are. Next, I'd like to go over a case scenario. An individual is 58 years old. He's a male. He lives in an adult foster home with a caregiver. He's been diagnosed with asthma, lung disease, and a chronic cough. Keep in mind all those conditions that I said leaves you at risk for dysphagia or aspiration, and also the possible signs when I go over these cases. So his services are in the home or supervised by an agency supervisor, not a nurse. There's no training and consultation nursing on board. The PCP prescribes an inhaler for asthma and lung disease, and cough syrup with coating for the chronic cough to be given as needed for cough. And usually there's a parameter of, say, every 4 to 6 hours if coughing. So this individual actually has a more persistent and frequent cough, How often do you think he's being given that cough syrup? Probably every 4 to 6 hours. He also now has a poor appetite. Is there anything next that comes to mind? What would you be concerned about in this situation? He has asthma. He's got that persistent cough. Now he doesn't have an appetite. Now, how would you respond? And I know this is not an interactive environment, and who would you call first? Would it be the guardian, perhaps the primary care provider, service supervisor? Call someone, notify someone. If you listen to your gut, and I'll tell fellow nurses, when we're talking about different, listen to you. If you have a gut instinct that something isn't right, take action and look at what your next step is and act on it. So next. So as an outcome of this situation, the caregiver has the ability to continue to administer the cough syrup as ordered. The PCP ordered it. She has it. Individual doesn't have a fever, so there's no infection going on at the time. The caregiver is unaware, though, there's sedating side effects of the codeine that also decrease the gag reflex. And if you're providing somebody with codeine every 4 to 6 hours, the codeine doesn't fully leave your body in 4 to 6 hours. So you're kind of adding on a little bit more each time. So he continues to cough. He's medicated as ordered. He was found unresponsive in his bed. EMS was called. He had low blood pressure, hardly breathing. He had aspirated his food and oral secretions and later died of aspiration pneumonia and sepsis. Now, could this individual have had dysphagia? And with the feedings and he's coughing, he's not tolerating his food. And then also, he's been given the cough syrup within the order. The order was there, but still all of these steps led to the aspiration pneumonia. Next. So how could we have handled this better? Now that you have the tools, you have some knowledge of dysphagia, you're aware of the warning signs, and you're aware that communication is key. Contact that PCP, the agency supervisor, the guardian, let them know there's a concern there. That would all help. Next. In another case scenario, this individual is 62. He has a history of recurrent pneumonia, it's moderate ID, he's limited in his communication skills. He's also diabetic, hypertensive, and obese. Now, this PCP orders a swallow eval due to the history of pneumonia that confirmed dysphagia. The results of that swallow eval, a special puree diet was ordered with nectar consistency liquids. What does this circle need to know to safely support this individual? Next. And additionally, keep that in mind. Additionally, this case was reassigned within DD, within our case management. Perhaps the person moved. It was assigned to another case manager. There was no reference at all in the ISP to an altered diet. No, I'm sorry. The only reference was to an altered diet, but there were no risk factors or diagnoses and no medical order for thicket. Aspiration risk was not addressed in the ISP or action plan. Now, noting and picking up the ISP and you just see an altered diet, would that cause you to question and go, okay, something is different here. What do we do? That's where the communication comes in next. So what interventions? Contacting the agency supervisor to, advise of new orders. If the person has a new diagnosis of dysphagia, what's the new orders? Making sure there's special diet training, positioning instructions during and after the meals. For the agency supervisor, utilize an RN or request for TNC RN services to be authorized from DDD so that you can have the nurse review, oversee the individual, educate the caregiver on the meal preparation, positioning, and make sure that all the medical orders from the PCP are also followed. And the case manager can then go ahead and make sure that all the documents in ISP, action plan, all have current diagnoses and recommendations. Now, when someone transfers either from one unit to the other or from one residence to the other, a transfer summary and checklist needs to be completed, where it indicates all of the diagnoses, all the red flag areas, and the dysphagia would be one of them. Verbal reports between case managers and reporting between, say, the provider agency had changed as well. Good communication, you're going to safeguard that individual. And utilizing a unit nurse. Now, we have unit nurses in all units on Oahu, and our Oahu nurses also cover neighbor island case management units. So there's always a nurse available. I'm sit on the clinical team. I provide support to the units as well. And our clinical team can, or what we call CIT, can always be accessed for recommendations. Next. And Linda will be going over this last case scenario.
Sorry, Steph, we are about to run out of time. Would it be possible if you could help us close out so we can have a few minutes for question and answer?
Okay, so would we like to pass on this one then? Or I can just go over it?
Yep, so we're on the road to safety.
Okay.
And then the conclusion slide.
Okay. So you've gotten a lot of information today. I thank you for your time. Our road to safety includes education, communication, and collaboration. And in conclusion, we provided you the tools to help you, and I hope this has been helpful. You can understand the importance for early detection, recognizing the signs of dysphagia, and implementing steps to safeguard the individual. I thank you for taking your time. My research, all the articles that I had citations of are included in the training website as well. Thank you so very much.
All right, everyone. So we have a few more minutes to go ahead and talk about question and answers for today. So if you folks can go ahead and submit your question through the Q&A panel that you see below or on top, and then we can go ahead and help answer your questions for today. So the first question that we have coming through is, this is for Linda. What does health decay smell like? Tooth health decay smell like?
Okay, what people confuse bad breath decay or bad bacteria breath with other things is garlic and just a stale morning breath. The stale morning breath, garlic breath, onion breath, they're very, you can identify it. But when you smell bad bacteria breath, it's something that will hit you and go through your system. It'll be like a cloud around you and you can't escape it. And whenever the person talks, you just feel kind of weak. If anybody has experienced that, I've experienced it several times in my lifetime. Recently with a sales rep that was talking to me. So I knew it wasn't his toe jams, but I mean, you can tell when you smell bad bacteria breath. That's why I wanted to identify it. I hope that helps.
Awesome. Thank you so much. The next question that we have is for Stephanie. Can we get a copy of your research? I love to see your work as a published author.
Oh, I do. I'm sorry, I don't have, it's not published, but I do have my research citations that will be available at the on the training website. Thank you, though. Appreciate it.
Okay, so we are coming up to the top of the hour. Does anyone have any questions for our amazing panelists that we have here today? Last 3 seconds to get your questions in. All right. Again, thank you so much, Stephanie and Linda, for joining us today. And thank you to everyone for joining in on our first Tuesdays training series.
Thank you, Abby.
Thank you.
Thank you, everyone, for joining us.
Mahalo, and thank you for joining us for this month's installment of DDD's First Tuesdays training series. Should you have any additional questions for DDD's training unit, please feel free to email us at doh.dddtraining@doh.hawaii.gov.